button. Thank you. The recording will be posted on the board's webpage shortly after this meeting, and I'll send an email out to board members notifying folks, and then we will also be following up with a Gov delivery with that link as well. TBW may also be streaming this meeting live and archiving it for additional viewing opportunities. As always, we have a full agenda, and it can be found in the first tab of the meeting materials. And before we hop in, I just wanted to give a couple quick updates. Today, you may have noticed we have some new microphones. An issue at past meetings had been some difficulty hearing folks. So we're very excited to be using these. Just some quick directions for folks that are in the room with us today. And if you look at your microphone, there is a tab with a person and a couple rings coming out. If you press that, it'll go green. If it's green, you're live and you will be able to be picked up. These are very strong microphones. You don't need to put your face directly to the microphone. It should be able to hear you great. When you're done speaking, press the button again. It'll blink red and then go dark. Then you're off. We ask if you're not speaking that you please mute your microphone to prevent feedback. And I think that is it regarding microphones. Would love to hear any feedback folks have afterwards in terms of if this improved your experience to be able to hear folks in the room, as we really want to make sure that you're able to hear. I also wanted to provide one other high-level update before we get into the meat of the meeting. We'd previously talked about bringing attribution back as a topic, and we're still currently in the internal process of reviewing different modes of attribution, reviewing the comments that we've received in the past regarding attribution, and thinking of different methodologies and ways to consider that, which we plan to bring back to this board in the future. So just wanting to keep you abreast of those updates and continue to update you on our plan and when we think that that topic will come back to the board. Now I'll turn it over to Michelle, interim chair of the cost board, to call the meeting to order.
Thank you, Ross. Sound check. I think we're in good order here, and we'll start the meeting. Thank you all board members for joining today and sharing your time and patience with us as we continue this journey together. We're very excited to have people join us during this busy end of legislative season. I know it's been hard to get away for some of us. Are we reviewing the agenda, Ross, before we do the roll call, or just we're right into roll call?
I think we'll just go right into roll call.
Well, I'll turn it back over to you. Roll call.
Excellent. Thank you, Michelle. I'll now turn to roll call. I'll call out the name, and if you're present, say present. Start with Jane.
Present.
Jane Byer, present. Thank you. Eileen Cody.
Present.
Thank you. Lois Cook.
Present.
Thank you. Bianca Frogner is not here with us today. Ken Gardner.
Present.
Thank you, Ken. Jody Joyce is not here with us today. Greg Marchand.
Present.
Thank you, Greg. Mark Siegel. Mark Siegel. Not here with us today. Margaret Stanley.
Here.
Thank you, Margaret. Ingrid Ulrey. Ingrid Ulrey. Okay, no Ingrid today. Kim Wallace will not be able to join us today. And Carol Wilms. Carol Wilms. Okay, is not able to join us today. Apologies, I'm just counting to see if we have a quorum here. We are not voting. Yes. Yeah, so we are not voting today. It does not look like we have a quorum. So I will now turn it to Michelle for approval of the March meeting minutes. Thank you, Michelle.
Thank you, Ross. Let's turn to tab 2 in the board materials. March meeting summary. Also is on the screen at the moment. So as usual, I see Margaret's hand up. Yes, Margaret.
Yes, it's difficult to hear you, Michelle.
Okay. You bring the microphone closer despite the instructions. All right, how's that? That better, Margaret? Is that an improvement?
Yes.
Excellent. So we're turning to tab 2 to look at the March meeting summary. It's also on your screen at the moment. As usual, we will use the consensus process for a vote on the approval of that meeting summary. Is there a motion to approve the minutes?
I'll make a motion to approve the minutes.
Lois?
All second.
Thank you. Motion is second. All in favor, say aye.
Aye. Aye.
Any opposed? Margaret has her hand up. Oh, you're on mute. Margaret, we cannot hear you.
Sorry, just a point of order. I thought we weren't voting today because of not having a quorum.
I mean, approve meeting minutes without a quorum, Ross. Just approve them for the moment. We can revisit that with vice for.
Excellent. Yeah, and I can follow back up on approval of meeting minutes without a quorum.
Thank you for that clarification, Margaret. I heard a number of people saying aye. Any opposed? Right. Motion approved with clarification that Ross will double check our quorum. All right, with that, I think we'll slide into tab 3 and public comment. I will turn this back over to Ross.
Thank you, Michelle. Now we will turn to tab 3 in your meeting packets and begin the public comment period. Written public comments that we've received since the last meeting are in the 3rd tab. We also encourage individuals to sign up to provide public comment before the meeting, and we'll start with those who have signed up in advance. If you've not signed up and would like to provide public comment and are participating virtually, please raise your hand, and then we'll call on you after we've gone through the individuals who have signed up in advance. When you're called upon, please state your name and affiliation, if any, before speaking. And for those attending virtually, if you raise your hand, please accept the invitation to become a panelist in order to turn on your camera and provide public comments. Today, because we have a number of public commenters, we have a 2-minute limit per public commenter, and you should see the timer on the screen. And also today, just wanted to point out with our new microphone setup, we ask that any public commenters in the room come up to the microphone. Again, if you just press the tab, it'll turn green, and then you are ready to provide your public comments. So turning today's public comments, starting with those that have signed in or provided comment in advance. I believe first we have Jonathan, who will be speaking to some comments that we received from Wisha.
Oh, yeah, if you wouldn't mind coming to this microphone, that'd be great.
I apologize. Thank you.
No, he just messaged me that he thinks because you're going to be considering attribution methodology later, it might be better to just save that comment for then instead of providing it now.
Oh, okay. Excellent. And then I believe you had a public comment. Okay, thank you.
To hear.
Yeah.
I'm sure where to look, so I'll just go straight.
Cameras over there doesn't capture very well.
Oh, okay. Well, I'll do it up here. So my name is Katarina LaMarche. I'm a policy director at the Washington State Hospital Association. My comment today is in response to the agenda item on strategies to address hospital cost growth, and we'll submit a letter afterwards that provides more information. But we wanted to make a couple points before you consider. The presentation concludes that hospital prices, the payments that hospitals receive for the services provided, were the #1 driver of commercial spending growth, even though inpatient growth has been flat and outpatient growth was less than the growth of prescription drugs. Many of the strategies offered for your consideration would cap hospital prices, but it isn't quite clear from the analysis prices are the problem. On points, cost driver analysis and UW's findings combine price and intensity, but here it's just labeled as price. And so we're hoping to ensure that we're determining the impact that intensity has before concluding that prices alone are the driver and therefore the problem. The analyses also don't show that there's an issue with the total amount of hospital revenue. Hospital margins in aggregate are still negative, and the prices, according to the RAND report cited, are generally average when compared to other states. The analysis also don't consider the reasons why outpatient spending appears to have increased, or at least not adequately, when it might simply be the way that costs are assigned to spending buckets. For example, some of the increases in outpatient use are a result in care shifting to outpatient, and some of the outpatient prices are a result of increasing intensity as care, especially some surgical care, has been shifted from inpatient to outpatient. Materials also seem to conclude that the price of hospital care should be lower, but there's no analysis of what's driving growth for hospitals, like drugs and supplies, equipment, salaries. Salaries alone have increased 35% since 2019. So our question is, will an arbitrary cap on hospital revenues lower the cost of salaries or supplies? And where, besides patient care, are hospitals still supposed to make cuts when they have negative margins as it is? So we just ask that you perform a deeper analysis to better determine problems and ensure that the strategies you have selected or will select solve those problems. And we would also welcome the opportunity for you to meet with our members to speak with them about the issues that they're having before you move forward with strategies. Thank you.
Thank you, Katerina. I believe we have next Fran Marisa. Thank you.
Staff that they're having a hard time hearing, so if you could pull the mic close.
Yeah, I'm having some trouble hearing.
Yes. Please go. Okay.
Hi, good afternoon. My name is Fran Mariso. I'm the owner of Professional Medical in Seattle. We are a small women-owned medical supply company, primarily providing fee-for-service Medicaid patients with their monthly incontinence supply needs for the last 29 years. I believe we do a really good job at what we do, as well as my competitors. Some are here, some joining us by Zoom today. I wanted to comment here today about the proposal our industry was just made aware of recently regarding the Healthcare Authority planning to contract with a value-based plan in another state to provide these supplies to fee-for-service patients in a preferred supplier agreement. We were not aware that hca was looking to move to a value-based plan for these supplies. Personally, I've been watching the MTP documents as well as the value-based roadmap and haven't seen anything regarding durable medical equipment and supplies. But we wanted to make sure, given that this is something that we've been told is in the works or being looked at, that you are aware that as a local supplier community, we are ready, willing, and able to work with you to help you achieve those goals if that's the road that you're intending to take to accomplish goals of cost containment and better care through a value-based approach. We do believe that the investment in providing these products to patients does help dramatically reduce hospitalization and skilled care costs and improves their overall care. We have always worked together to achieve common goals in the past, and we ask that rather than move to an outside contract, if the state is indeed looking at moving to a value-based approach for incontinence and urological supplies, it once again works with our industry association and our local suppliers to facilitate this change. This would allow for continuity of care for our vulnerable patients, keeping our local business open, as well as working to achieve the long-term goals of hca. Welcome any conversations, discussions, and would love to hear more about what the plans are. So thank you so much for your time.
Thank you so much, Fran. And I just want to check, were folks able to hear Fran's comments?
Yes.
Thank you very much, Fran. And I believe those are the three individuals we had signed up in advance for public comment, but I see we have a couple extra folks here. Would you like to give public comment? Thank you. Excellent. Yes. And if you could just introduce yourself and your affiliation before your public comment, that'd be great.
Hi, my name is Graham Smith. I'm the Vice President of Business Development for Soundview Medical Supply. We're a Seattle, Western Washington-based medical supplier. We focus primarily on the senior care resident community in Washington. We supply over 2,000 adult family homes and several hundred assisted living and memory care facilities throughout the state. And again, it's regarding incontinence supplies. couple things. First is the transparency level of trying to discuss this and involving local stakeholders. So that would be something we really encourage and would hope to be able to speak to, specifically with incontinence supplies. It's not something that's looked at as treatments and outcomes at medical schools. Doctors don't have a lot of training, a lot of background in the treatment and care for folks struggling with incontinence. And so as a supplier, we've actually are kind of the product knowledge and industry experts that have a lot of information that's available to how to properly care for folks and get desired outcomes. So we'd love to be a part of the conversation and discussions with that. And second is just kind of speaking to the value-based or sole source contracting. In other states, we are also work with industry professionals, and there's a pretty dramatic drop off at the level of care because they go to a one-size-fits-all approach. And with people, they're not all one size. With incontinence, it's a continuation. It's not a single solution type treatment plan. So with that, you see a lot more people falling, a lot more UTIs, a lot more folks that are showing signs of dementia that are related to UTIs and getting treated for dementia when they in fact just need better incontinence care. So thank you. Appreciate your time.
Thank you so much, Graham. Do we have anyone else present today in the meeting room that would like to provide public comment? Not seeing any additional, are there any additional hands virtually that would like to provide public comment today? Margaret.
I have a question for the representative from the Hospital Association. We're going to be looking at various cost control approaches for hospitals at the meeting today. And I've been wondering about what the financial results of the hospitals have been in the last year as we look to try to hold down their spending. I'm wondering if they're making money, losing money, some of each. You know, I hear that a number are losing money, and I'd just like a comment on that, please.
Thank you, Margaret. We'll not have them respond at this time. They can send some comments to us in writing.
I couldn't quite hear that.
We will have them send comments to us in writing at another time.
Thank you, Margaret. Yeah, we'll note your question and connect with those and can bring that back up. Thank you. Or do we have any additional public commenters?
Hospital Association rep is not in the room at this time, Margaret.
I would like to request 2 minutes of time as well. This is Laura Berry.
Sure. Please go ahead, Laura. Introduce yourself and your affiliation and go ahead.
My name is Laura Berry. I'm the owner of Soundview Medical Supply. We've been a provider in Washington State for the last 23 years. And as Graham had mentioned earlier, he works at Soundview as well. We do focus on providing to dual eligible in primarily senior care facilities. My concern is about the value-based program and an attempt to save funds by following through on what they think would be a lower cost to provide. Excuse me. My understanding is that they're offering to lower the cost by providing higher quality products, which would lower other expenses, hospital stays, for example. And I just wanted to point out that Washington State is one of the states, the very few states, that already provides a higher quality product than almost anything that you could get in anywhere else. So you're not going to save money by getting a better quality product. As a matter of fact, you could be jeopardizing the relationships and the health of the enrollees that you have by what would turn out to be a lower quality product. We also do not ship the maximum that's available. And I believe that the value-based program has promised that they would cut costs by lowering the quantities that are supplied. So that already does not happen in the state of Washington. And I think I'm about out of time here, so thank you for listening.
Thank you, Laura. Do we have anyone else participating virtually who would like to provide public comment today? Okay, not seeing anyone else. Thank you to everyone who provided public comment today. Again, this meeting is being recorded, and if you missed any public comment, you'll be able to review that again in the recording, and that should be available shortly after the meeting. And now I will hand it over to Michelle to go over legislative updates.
So just quickly, Ingrid is online now.
Oh, excellent.
Great. Great. Thank you, Russ. We'll now turn to tab 4 as Audrey's already got us there. Thank you, Audrey. And we'll prepare to talk about our legislative update. I know we've got Evan Klein on today, who's our legislative director for your authority. It's a brief update. Some of the current activities. The legislative session is still live.
To be a shorter distance
Carol,
to walk because there's a tight spot up there.
Carol, you need to mute, please.
Yeah. Oh, hang on.
Thank you.
Thank you, Audrey.
Right, Evan. Are you able-
Great. Yeah, happy. Can you hear me in the room and
Yes.
online? Perfect. Thanks. For those that I don't know, I'm Evan Klein. I'm the Special Assistant for Legislative and Policy Affairs. So lead our legislative relations team here at the State Healthcare Authority. And I appreciate the opportunity to come before you today. I think I only have a couple minutes, so I will stay relatively brief. But just wanted to give you a kind of a short update on where we are with the state legislative session. For those who have been tracking, we are nearing its end, hopefully. Fingers crossed, knock on wood. The sine die is set for Sunday this weekend. So the legislature is working through kind of the final throes of their budget development process and passing both the budget, but all of the bills as well that have to ride with the budget, including revenue packages this year, to try and get a balanced budget enacted and allow them to get out on time on Sunday. So we, as many of you are sitting and watching that process play out a bit from the sidelines at this point, but have been doing a lot of engagement over the past couple of months. So want to just give you an update on two pieces of legislation that have been really close to us here at the Healthcare Authority. And I know we've talked about the cost board previously. The first is House Bill 1382. This is a piece of request legislation that HCA ran this year around the state all-payer claims database. The bill seeks to amend our state's APCD statutes. One, so that the agency can function as the lead organization for our state's APCD in the event that there are no successful third-party bidders to run the program. But also to expand the type of data that can be shared out of the APCD through analyses, largely to include negotiated rates between providers and health carriers. This is information that the state currently is prohibited from sharing out of its all-payer claims database, but that providers, facilities, and health carriers are required to publish under federal transparency and coverage regulations. So there are federal rules that have been in place since 2020 that require publication of negotiated rates attributable to a provider and a health carrier at the federal level, but we can't share that information out from our APCD. So that we're happy to say is going to be changing here within the next year and a half. The legislation has passed both chambers and is off to the governor's desk, where we hope that it will get signed and enacted and will allow us to start sharing analyses out of our state all-payer claims database and allow any other third parties to use that analyses as well and use that information. So providers, small businesses, policymakers, others, and I imagine the cost board as well, to take information related to negotiated rates and process that for various healthcare related analyses, and that'll be effective July 1st of 2026. So we're happy to see that bill make it to the finish line. And then the other piece of legislation that we had been working really closely on this year was Senate Bill 5083 and its companion, House Bill 1123, but the Senate version became the vehicle through the legislature. And this was related to our public and school employee benefits programs and establishing reference pricing in those programs. So really thinking about access and affordability challenges for over 500,000 clients that we serve here at the Healthcare Authority that are both kind of public servants, on the public employee side and within our state's public schools. That bill has now passed both chambers. It still has to go through a concurrence vote in the state Senate, which we imagine may take place today or tomorrow. Saw it up on an order of consideration for concurrence earlier this morning, but I know the Senate is currently at ease. The bill has been amended throughout the process. So I think we've talked about it with you a couple of times throughout the past 6 months. The bill was amended to carve out and create some exemptions for certain hospitals, largely focusing on smaller rural facilities, our state's critical access hospitals and sole community hospitals in particular, as well as a couple of others that were exempted from regulation in the bill. But still includes a payment cap at 200% of Medicare levels for many of our state's largest acute care hospitals, and then some floors for reimbursement for primary care and behavioral health services within our programs. So we're hopeful that it will allow for generated savings for health plan enrollees, reducing their premiums for public and school employees. It creates some savings to the state because we pay the employer contribution for insurance for these individuals. And then it also reinvests some of that money and increases reimbursement for critical primary care and behavioral health services, preventive services that we know some investment is needed in. So we're happy to see that make it across the finish line. I imagine we'll have the opportunity to talk in more detail about implementation, about that legislation later in the year with you all, or answer any questions offline that you might have. But just wanted to take the chance to say thanks for all those who had engaged with the agency throughout that process and let you know that we're now kind of relatively across the finish line with both of those bills at this point. With that, I'm happy to turn it back over or be available for questions, whatever works for us and Michelle.
Great, thank you, Evan. I'm just looking to see if there's any questions from board members. Not seeing any hands at the moment, so thank you so much.
Michelle, can I ask a question? What?
Yes, Ingrid. Question? Go ahead, Ingrid.
Oh, thank you. Evan, can you speak to the primary care bill as well?
To the, are you referencing the primary care reporting bill? Yes. So I'm going to check my notes on the bill number. So that's Senate Bill 5084. This was legislation that the Office of the Insurance Commissioner ran related to primary care reporting, which we are excited about. It's largely building some, kind of growing on some of our partnerships here around reporting on primary care expenditures. The agency HCA has been requesting that our health carriers and managed care organizations report to us on primary care expenditures through kind of a template format for consistency and standardization across carriers to give us a better picture into primary care spending. We see a lot of the claims, but we don't necessarily see through claims any supplemental payments that may be going to primary care providers, incentive payments, capitated arrangements, other payment arrangements. So we've created this reporting requirement, and the Insurance Commissioner's Office is working to align that reporting for fully insured commercial insurance carriers. So we were excited to see legislation pass this year. We didn't run it, doesn't directly impact the agency as much, but that will allow the Insurance Commissioner's Office to collect a lot of the same information in a standardized format. So I know we'll be working with them and the exchange throughout interim to implement that bill. But that's a great point. Thanks, Ingrid, for highlighting it.
Thanks, Evan.
Thanks, Evan.
She'd like to speak to that for a moment.
So actually, just a really quick update. Thanks, Evan. That was perfect in terms of the bill. A couple of other bills. Senate Bill 5579 is on its way to the governor for signature. We know that when there are contract disputes between health insurers and hospitals and other providers, those sometimes get very public in terms of op-eds and letters to patients. And Senate Bill 5579 essentially establishes a level playing field that says neither the insurance companies nor the providers can send out public notices until 45 days before the date that the contract would terminate. So doesn't seem like a big deal, but if you're an individual who gets one of those letters, it's a big deal. And then just really quickly, House Bill 1432 is a major behavioral health bill that passed the legislature that applies to commercial health plans, including PEB and SEB, that relates to things like the clinical standards that health insurers use when they're reviewing whether somebody needs care, and also puts into state law some strong federal rules that were adopted around the federal mental health parity statute, so that even if the federal government repeals or modifies those rules, they'll still be law to Washington state. And that one is also on its way for governor's signature.
Great, thank you, Jane. I know we'll have a little bit more comprehensive review of some of the related legislation that we've talked about in front of the board and with our sister agencies in the June meeting, since we'll wait to see what truly is passed at the end of the day and include some of the related budget items that will likely impact some of our work going forward as well. So thank you, Evan, so much for this update, for all your work this session. Appreciate your time today. Right, and I think we can turn to tab 5. So, introduction to more discussion on hospital expenditures. At this time, I'll invite Harrison Fontaine and Michael Baylett of Baylett Health. They will provide a high-level review of some of the reports that the cost board has already looked at, just as a reminder, a brief introduction and reminders of that work, the cost driver analysis, the benchmark reports and other analysis that Washington State has looked at over the last year. And so then Michael Baylett will introduce some policy levers that we will continue examining together this meeting and probably over the next several months. That I think we'll just turn to you, Harrison.
Good afternoon, members of the board. Harrison Fontaine, I am a senior health policy analyst for the cost board. I'm going to be talking today about some background data from the state of Washington concerning general growth trends and also hospital cost growth in particular. Before I get started here, at the last meeting that I presented at, the board expressed interest in having the staff to the board be more focused on supporting policy work that the board is doing, and this is an effort in that direction. Next slide, please. All right, so just a reminder of some directives. Legislative directives to the board. Today we're going to be talking about a few of them, looking at identifying trends in healthcare cost growth and analyzing total healthcare expenditures. And the idea here is we'll be looking at Washington specific data that should support the board's work in evaluating and looking at policy options and ultimately providing policy recommendations. Next slide, please. So again, before we get into the data, I'd like to also look back for a second at past topics that the board has focused on. You can see a few of them really broadly summarized here, but they include things like increasing utilization of primary care. This was definitely a major focus of the last year and something the board made really good progress on. You can see some of the actions here. In addition, the board also focused on identifying ways to increase oversight of mergers and acquisitions, essentially business oversight, and also addressing hospital cost growth. And these are very meaty topics, there's a lot there. And so in trying to further focus the board's efforts, today's presentation will be considering some recent data work, some recent information that the board has received, trying to digest that a little bit and say something about where the board's priorities might lie in the future. Next slide, please. So when we begin to dive into the data and look at healthcare cost expenditures over the last few years. We can see graphs like you see here on the right, where we have we have service categories in different colors across the years, and we can consider from this data ways to pull out top categories that are contributing to either overall spending or spending growth. And so that's what we'll be doing in the following slides. So we can first take sort of a broad view of things across all markets and look at identifying perhaps 3 top contributors, either by total healthcare expenditures, or by total growth. When we start off that list by identifying total healthcare expenditures, total top contributors to total healthcare expenditures, we see things like hospital inpatient and hospital outpatient, here shown in this line graph in blue and orangish red, popping out as top contributors. We also see prescription drugs as a major contributor. When we switch to identifying top contributors by healthcare cost growth, we can add another to that. And pulling up the top 3 here, we also add this non-claim service category to the list. And as we think about these top contributors as things that we might have, we might develop policies to address, it's important to also note parallel efforts that are going on that might be interacting with these categories. For prescription drugs, we have parallel efforts within the Prescription Drug Affordability Board, or PDAB, that are aimed pretty squarely at addressing this increase in prescription drug costs. In addition, when we think about non-claims and the growth in that category, a few things to note there. One thing is that we would expect this growth in terms of things that would be coming on the back end of payment reforms. Additionally, the growth that we see here in this overall cross-market look at spending and spending growth, this growth in non-claims is coming mostly from outside of the commercial market. This brings us to our next slide, where we can sort of narrow in a little bit on commercial spending, which really is one of the central focuses of the cost board and something that policy efforts should be addressing. And when we go through that list and identify top candidates in a very similar fashion, we see a similar list. We see hospital outpatient and inpatient contributing substantially to overall healthcare expenditures, as well as to growth. We see again prescription drugs on this list, and then this additional category of professional specialty care. So from this brief overview, essentially what we're pulling out is we see a lot of potential places for the board to focus their efforts. These are all good options for potential policy interventions. One thing that we see again is hospital outpatient and inpatient appearing on these top contributor lists and as something that the cost board has identified as an area for potential policy interventions. So let's go to the next slide. We can consider what might be underlying this, and reviewing some of the past work that the board has seen, but it's been a little while and there's been a lot of data coming lately. We can pull out a few sort of top line conclusions from these different reports that the board has seen. First, when we look at a financial analysis performed by contractors Bartholomew and Nash that I believe the board saw last year, we see price and cost per patient are higher for Washington hospitals than for peer hospitals, according to that analysis. And additionally, when we look specifically at the commercial market, we see that reimbursement rates are about 2.5 times what they would be if Medicare were paying for those services. Then lastly, when we look at our cost driver analysis, this is cost driver analysis performed by OnPoint using APCD data. Essentially, when we look at price per service, either looking specifically at hospital outpatient or hospital inpatient, what we see is increases across the board in price per service, and that those increases in price were especially dramatic in the commercial market and the exchange market. This is looking at the time frame between 2017 and 2023. So this is all to say, essentially, if we're looking across states, if we're looking across markets, or if we're looking across time, it seems that prices for hospital services in Washington are relatively high and are also increasing. So let's go to the next slide.
Harrison, I see a question from Jake.
Sure.
Thanks, Harrison. So question, and I don't know whether you're going to get at this with the next set of expenditure data. So non-claims, a big chunk of growth. Commercial, not so much. But I guess the question is, do we have any information about where those non-claims payments are going? Do we know if they're going to hospitals? Do we know if they're going to individual providers? Because it seems like that's information that helps us understand trend across the other categories as well.
Yeah, that's a fantastic question. I believe we do have some data on that. I don't know off the top of my head exactly where those payments are going, but certainly something that we can follow up with for the board in the next meeting.
Yeah, I mean, if we want the whole picture, right?
Certainly.
Okay, thanks.
Okay, so just some summaries here. Essentially, looking at two different analyses, our cost driver analysis and our benchmark analysis, we see that healthcare costs are going up, and we see costs in these sort of frequent flyer key service categories that reappear regardless of sort of how we slice and dice things. Additionally, hospital spending was consistently identified as a top contributor to total medical expenses, and that hospital expenditures, especially within the commercial market in Washington State, are rising. It's our hope that these analyses will sort of inform you as we go into Michael Bailiff's presentation, where we'll be discussing options to address hospital spending, and certainly looking forward to future follow-up analyses on these data. With that, I will pass it over to Michael.
Hi, good afternoon, everyone. My name is Michael Bailiff. Some of you will remember me because my colleague January and I worked intensively with all of you 4 years ago when you were creating the cost growth benchmark. For those of you who don't know me, my firm is working with most of the cost growth benchmark states, and it's with that perspective that I am going to share with you a cross-state perspective of approaches to hospital cost growth, why states are looking at it, and what are some of the approaches that they're taking. And I welcome your questions along the way. So let's go to the next slide. Has the agenda of what I'm going to cover. So I'm going to give you a little bit of a step back forest view on this topic, and then I'm going to review a highly specific set of state strategies to address hospital prices with a focus really on the commercial market. And then we'll have time for discussion. Okay, let's go forward a couple of slides. All right, so for all of the states with cost growth benchmark programs, their initial focus was beginning to collect data and to report data and creating a level of transparency about healthcare spending in the state that never existed before. But after mastering that data collection reporting task, states have found that the mere reporting of spending data and of annual trend has not been enough to slow spending growth. I'll note that it does appear that it was enough to slow spending growth for Massachusetts for several years. Massachusetts was the first state to do this, but it's no longer working in Massachusetts, and it doesn't appear that it's working in any of the other states that subsequently adopted a cost growth benchmark. So your fellow travelers in this affordability journey, these other states, are now developing policies in different ways at different paces to address the drivers of healthcare spending and spending growth. And Harrison's brief presentation before this did a nice job of showing you where is spending growing fastest, particularly in the commercial market. And within the commercial market, not just in Washington, but in other states as well, spending growth has tended to be fastest when it comes to hospital spending and specifically hospital prices, and in drug spending and in drug prices. So I'm going to focus today on the approaches that states are taking when it comes to hospital prices. Next slide, please. So why are states focusing on hospital spending? Well, this is a different format, but it's essentially the same story that Harrison just showed you. His graphics show that about 50% of spending, if I counted that right, is going to hospitals. And you can see across the country, it's actually a little bit less, but approaching 50%. It is the largest component of commercial spending. If we included here employed physicians of hospitals and attributed that to hospital spending, of course, would be even larger. Hospital outpatient spending has been the primary driver because hospital inpatient utilization has been flat or declining across states, whereas hospital outpatient spending has been growing rapidly, a factor both of utilization growth and of increases in price. So that's where the highlight is when it comes to hospital spending. It's really been in outpatient spending. Okay, a little bit more on hospital spending from a national perspective. Next slide, please. And this is analysis that comes from the Healthcare Cost Institute that collects data across states. They found from 2018 to 2022, hospital prices were the #1 driver of commercial market spending in the United States. The other states that are participating in the Peterson-Milbank program have all identified hospital spending as a primary contributor. A little note here. I'm using the word prices, but I don't actually mean prices because prices are what hospitals charge, but hospitals don't get paid what they charge by and large. What we're really talking about is what they get paid. And so technically, we're talking about payment per service unit. So a service unit on the inpatient side is a discharge. On the outpatient side, it's any number of service units, an X-ray, outpatient visit, a lab test. So that's what we mean when we say prices. We really mean payment per unit of service. So why are states coming up with new strategies for hospital spending, aside from the fact that there's a lot of spending and it's growing quickly? Next slide, please. The reason is that cost growth benchmarks are not effective in holding hospitals accountable for their contributions to spending growth. Because with the cost growth benchmark, we are creating accountability for total medical expense for a population that's attributed to a medical group or an IPA or an FQHC. But that's total medical expense. That's pharmacy, it's professional services, it's everything. And hospitals deliver a lot of services to patients who are not attributed to their employed or contractually affiliated PCPs. So we don't really have accountability for hospital spending growth and specifically for price growth through the cost growth benchmark. And so states are looking at additional mechanisms that can bring accountability that the cost growth benchmark does not bring. And additionally, I'll note that when we measure performance against the cost growth benchmark, because of the way that data are submitted by payers, we don't get line of sight to the contribution of price versus utilization. Any questions about anything that I covered so far? Okay, so I'm going to do one more step back slide and then I'll get into the strategies. So I look back in my records and on March 15th, 2021, I presented a slide to you that looks like this one. This is actually a little prettier. And it was the logic model for a cost growth benchmark. Why would a state want to do this? We were talking about this in early 2021. And I want to review the steps of the logic model for a cost growth benchmark. So if we start up in the top right with the scales, this is measuring performance against the cost growth benchmark. You have now established this as an annual practice. The next step is analyzing what's causing costs to grow. And you are doing this now in two ways. You're analyzing your cost growth benchmark data, but you're also mining the all payer claims database because claims level data gives you more insight. So, for example, you can isolate price versus utilization using the APCD. And during your last meeting, I saw a presentation by OnPoint that did just that. And then step 3 is reporting both on performance against the benchmark and also reporting publicly on what's driving healthcare spending using that APCD analysis. It's not enough to stop your work there because you will not slow healthcare spending growth if that's as far as you go. So the rest of the logic model is identifying where there are opportunities to slow spending growth and to identify strategies to do so, and then to implement at least some of those strategies to slow cost growth. And only then will the cost growth benchmark program have served its purpose and slowed spending growth and hopefully increase the affordability or at least slowed the rate of non-affordability due to persistent spending growth. And so across the country, the states at different rates have moved past report and into identify and implement. And I think where you are from an evolutionary perspective is you are at the point where you are moving into identification and implementation. And through those steps, you'll be able to say, hey, we achieved the aims of our cost growth benchmark program. We have measurably slowed spending growth and improved affordability. Okay, so with that as an introduction, I'm going to review for you 7 state strategies to address hospital prices. We could go ahead a couple of slides, please. So the 7 strategies are grouped into 3 categories. One, on the left, these are strategies that are directly linked to the cost growth benchmark. The next 3 strategies are independent but support achievement of the cost growth benchmark. And the third one could either be linked or independent. All right, so I'm going to review each of them one at a time. If you have questions as I'm reviewing it, and you want to ask me to stop, please do so. Let's go to the next slide. So these strategies are not presented along a continuum of any sort, but I will say that this is probably the least intensive and impactful of all the strategies, but that doesn't mean it doesn't have value. And this is an incremental step from moving beyond reporting on cost growth benchmark performance to reporting on hospital price growth and naming names, being explicit. And this is something you can do leveraging the all payer claims database. We heard from Evan earlier that you're going to get the ability to actually report on individual hospital prices. So that would support this work as well. And this allows you to look both at prices at a point in time, for example, to look at price variation and look at what's the difference that's being paid for a given DRG or a given outpatient service across hospitals in the state. You can also look at what is the rate of growth in prices or payment per service unit over time and track what those differences are. And if you want to do something that's sophisticated, you can actually isolate changes in service mix and see what's happening and changes in prices over time. And I would say that if you are making comparisons, you need to be cognizant of differences in service mix, both comparing hospital A and hospital B because they won't be delivering the same services, but also comparing hospital B to itself over time to the extent that the services that are being delivered by that hospital might change over time. So what does this do? It certainly raises awareness of price variation and price growth, and it might serve as a catalyst for action on more impactful policy interventions. And on all of these slides, I'm citing a couple of states that have done this. Massachusetts and Oregon are two. They're not the only ones, but just two that I'm mentioning. And on the next slide, I have an example from Oregon of how they've done this. So this is looking at the change in median commercial payment over a 1-year period, from 21 to 22. And they are looking at one surgical procedure, appendectomy. So we're controlling for service mix here. And they're looking at how much payment changed in only 1 year. Their statewide median was 5.1%. So that's a pretty high rate of growth, certainly more than what household income grew probably that year. But you can see some very, very high increases at least selected hospitals. I'm not recommending that this be something that you do. I'm just trying to allow you to see a concrete example of what one state has done. You can see in the bottom there's a hyperlink to this report. Oregon will be publishing another report soon on hospital payment with more recent data. And there's a lot more in that report than just this graph. So that's the first strategy. A second strategy is to create a complementary hospital price growth benchmark. So this would be saying, all right, we have a cost growth benchmark for total spending. Let's create a benchmark for hospital price growth and focus in more narrowly on one of our cost drivers. In most states, this is possible to do if there's a statutory charge to promote affordability. And if I'm not incorrect, I think that's what you all have. The application of the benchmark could vary by hospital. Some states might choose to either exempt very small hospitals, critical access frontier hospitals, or hospitals that are performing extremely poorly financially. You could also vary your cost growth benchmarks by hospital. So California just did this. California is applying its cost growth benchmark for total medical expense, total cost of care. They're applying that to hospital prices as well. But just this week, in fact, they identified 9 hospitals with exceedingly high prices. And for those hospitals, they set lower cost growth benchmarks. So all of their hospitals have to restrict their price growth to 3.5%, but the very high price hospitals have to restrict their growth to 1.8%, dropping to 1.6% over time because of how high they are. So would this have impact to help you meet your state cost growth benchmark? Yes, it probably would. Depends on whether you have enforcement authority. So in California, the state does have enforcement authority, which you do not have right now. So that's obviously a factor. With the exception of California's new program, which is not quite operational, there are no examples of this in place. There are multiple states that are talking about this, and I know of at least 2 states that have committed to implement it.
Michael, Margaret had her hand up.
Yes, I was wondering what the enforcement mechanism would be in California.
Thanks, Margaret. So they have standard enforcement mechanisms both for their state cost growth benchmark as it applies to total medical expense and total healthcare expenditures and to prices. So those are performance improvement plans and financial penalties.
So the state can penalize the hospital for not achieving it.
They can. Yeah, they've not yet developed policies to do so, but they have statutory authority to do so.
Thank you.
Yeah.
Greg's hand is up as well.
How significant are the financial penalties compared to the size of the cost overrun?
Yeah, so Greg, they have not developed their enforcement policies yet. They only just finalized what their hospital price growth benchmarks are going to be. I mean, literally this week.
Oh, okay.
So yeah, they're not there yet.
Okay, thank you.
Mm-hmm.
Michael, if I'm correct, you can update me, but I think that we've only seen Massachusetts to date actually issue penalties for some of this activity, right?
Yeah. So in terms of enforcement, there are 3 states right now that have statutory authority. One is California, one is Massachusetts. Massachusetts Enforcement Authority is only for performance improvement plans. They cannot fine or otherwise financially penalize an organization for not hitting the benchmark. They can fine them for not submitting data and not being responsive in submitting performance improvement plans, but they can't fine them for not hitting the benchmark. The third state is Oregon, and Oregon has statutory authority for both requiring performance improvement plans and for financial penalties. And Oregon just began last year to set the clock for accountability for meeting its benchmark. They in terms, if I can remember this right, for financial penalties, you become subject to one if you meet the benchmark for reasons that can't be justified in 3 out of 5 years. But you can be required to do a performance improvement plan before that. So those are the 3 states that have enforcement power as of right now. There are other states that certainly would like it, and some that have sought it. Any other questions about this second strategy, the complementary price growth benchmark? Okay, let's go to the third strategy, and that is to tie the terms of certificate of need assessment and cost and market impact reviews to the cost growth benchmark value. So this means when the state reviews a request for a major capital expenditure or for a merger or acquisition, that it can require for in the terms of approval that prices be restricted to the cost growth benchmark value. This obviously is going to have more limited impact than something that affects all prices, but there are a number of states that have done this. Massachusetts, Connecticut, and Oregon are 3 where they say the written terms of approval are you get authorization to go ahead with this transaction, but you have to restrain your prices. And I have examples from Connecticut and Oregon on the next slide. So in Connecticut, they review both certificate of need, but also healthcare market transactions. And last year, they allowed Yale New Haven Health System, which is a dominant health system in the state, to acquire 3 hospitals from another system. But the terms of the approval were that commercial price growth had to be restricted to within 0.5 percentage point of their cost growth benchmark for 5 years. In Oregon, where the same agency that manages the cost growth benchmark program also manages their cost and market impact review program, which they call the healthcare market oversight program. They, when considering mergers and acquisitions, explicitly consider what impact approval might have on the state's ability to meet its cost growth benchmark. So they've completely linked these 2 policy initiatives and created an alignment. So 2 different examples from 2 different states of how you can expand the impact of cost growth benchmark to prices for certain state reviewed and authorized transactions.
Michael, there's a question in the room. Jane?
Michael, question for you. I know we've had discussions, in different venues with Connecticut. And one of the questions that always comes up is if you have, for example, these conditions on a certificate of need is granted, right? Entity does not comply. It's hard to ungrant a C of N. So are there and Oregon as well in terms of their HCMO program. What are their mechanisms or remedies if an entity that commits to this doesn't live up to it in practice?
Yeah, it's a great question, Jane. I have to confess, I do not know the answer. I'll note you not only have to have remedies, you also have to have a process for monitoring it.
Right.
Right? You can't say, okay, we got an agreement, hooray, walk away. You've got to make sure that they're adhering to it.
Yep.
But you're right. You also have to have remedies because you're not going to be able to walk back the merger approval or the authorization of adding a new wing to the hospital. So ideally, you would have some ability to levy penalties if they didn't meet it, and levy penalties worth at least what the failed compliance was worth. Thanks for your
Michael,
question.
could I ask a question, Ross Valore, HCA? So is the reason that you're tying this to CN because you're trying to parlay the regulatory authority under the CN program for enforcement that might not be available currently under a cost growth benchmark program?
Right. Yeah, Ross. So if you already had something like what California has, you would need to do this.
Right.
But
I guess
right.
I'm just thinking about Washington's Certificate of Need program, where we don't approve capital expenditures. We just approve new facilities are proposed, and we also don't do transaction oversight with that. So just trying to think in this case, but really the reason that you're mentioning CN is its regulatory authority is really the hook that ties these two programs.
Right. It's using existing state regulatory authority to advance the interests of the cost growth benchmark program.
Okay. Thank you so much.
Sure. Okay. So the fourth of my 7 examples is on the next slide. And this is taking action on some narrower hospital pricing policy issues. And I've grouped them together on one slide. One is implementing caps on out-of-network prices because it's sometimes a negotiating tactic where hospitals will say, we're not going to sign a contract with you, insurer, because we don't like the deal. So we're going to go out of network and we're going to charge many multiples of Medicare. So one approach is to cap how much out-of-network prices can be paid at. California's done that. Site neutral payments, which that's a very hot topic in Congress right now, mandates that you pay the same amount regardless of service delivery location. So if it's a hospital licensed site or a community site, you're paying the same amount. A bunch of states have done something here. I listed 3: Colorado, Connecticut, and Indiana. And again, maybe we're going to see some federal action here because there's a lot of discussion about it. That would be for the Medicare program. And then last, banning anti-competitive contracting, where dominant systems and hospitals can demand better terms than everybody else. And Nevada and other states have acted on this. So these will all have impact, but they're going to have less impact than something that covers all hospitals and all services. But if something broad scale doesn't seem feasible and you want to do something incremental, these are all incremental options that would have positive impact. Okay, 3 more strategies. So number 5 is establish a hospital price growth cap. So this is limiting how much hospital prices can grow each year. They're typically tied to economic indicators. So Rhode Island has this, and it's CPI plus 1%. This strategy has a lot of impact on spending growth and can be highly effective. There are 3 states that have this in a different form: California, Rhode Island, and Vermont. And I cited California before. California really belongs here rather than in the example earlier, because here it's a regulatory cap. It's not just a target, it's a cap. Rhode Island and Vermont have done these a couple of different ways. I want to focus on Rhode Island because It's has documented success, and it's been in place for a long time. So let's go to the next slide. They have a set of regulatory standards out of their insurance department, which they call the affordability standards, and they limit how much insurers can increase their prices to hospitals for both inpatient and outpatient services. And this is enforced through the rate review process, and the state conducts periodic market conduct exams to make sure that insurers are adhering to it. It's been highly impactful. I will say that of all the states with cost growth benchmarks, Rhode Island is the state that has been most effective. They've met their cost growth benchmark every year from 2019 to 2022. There's no other state that can say that. There was a 2019 evaluation in Health Affairs that showed that relative to a control group, which was the 5 other New England states, that there had been a decrease in total healthcare spending in the commercial population in Rhode Island. I will also add to this that next month in Health Affairs, there's going to be another new evaluation that was written by Andy Ryan at Brown University. And in a few more months, in a journal to be named, researchers at Harvard are going to publish an updated evaluation of this 2019 Health Affairs evaluation. So this Health Affairs evaluation looked at actual spending. The one coming, I'm sorry, yeah, this 2019 one. The one coming out next month is going to look at changes in premium and out-of-pocket spending. So there's good evidence supporting this, and I've provided a link to the 2019 journal article. Okay, 2 last strategies. Strategy number 6, Evan talked about earlier. So this is setting a hospital price cap, or what sometimes is called reference-based pricing. It limits how high prices can go. The Washington Public Option uses this, and as Evan shared a little while ago, there's legislation that's now passed your House and Senate to do this for public employee health plans. This can have a significant impact constraining hospital prices. Montana and Oregon have done this previously. Oregon's program was evaluated in a publication in Health Affairs earlier this year for their state employee health plans, and it demonstrated savings. I will note that there are other states that are considering this strategy for their entire commercial market. So your new legislation is just focused on public employee health plans, but there are some other states that are considering the application of a hospital price cap across the entirety of the commercial market.
Question. Right. So are they doing that just on the insured book of business, or how are they making a comment on how that's being done?
Yeah, great question. So technically, they can only do it on the insured book of business. I will say that in Rhode Island, where they have a price growth cap, the insurance commissioner has specified that insurers shall not discriminate against certain employers in the state when, or I actually I don't have the exact terminology, but they create a non-discrimination directive that somehow doesn't get out of RISA. And in that state, to date, the insurers have applied the price growth cap of their own volition to both the insured and self-insured markets.
Okay, nice.
But you're right, there is a limitation in any application of an insurance regulation to the fully insured market. There are some states that are considering applying hospital price caps, not through insurance regulation, but through provider price regulation. And if you do that, you get at the full market.
Thank you.
Comment in the room here as well. Jane? Michael, you just said the point that I was going to make. that there's the distinction between regulating the insurer, in which case you can't regulate the self-funded Blue Cross plan itself, and regulating the business practices of the provider.
Jane, I am flattered anytime I'm thinking the same thing that you are.
We've had these discussions. And actually, we discussed this in the affordability report that we put out at the end of last year.
Yeah. Now, to be honest, it's a little trickier doing it with provider regulation because states states have a chassis to put insurer regulation in place, but they often don't have statute for provider regulation. So if they already have it, then they're going to have to create it in order to do that. But there are at least a couple of states that I know of that are pursuing this, and we'll see maybe more in the future. Okay, the last of the 7 is to actually directly regulate hospital revenue. And there are a couple of states that regulate revenue and price growth. And these are Delaware and Vermont. This is literally looking at the budget of a hospital and its proposed revenue growth and price growth, and setting a cap on revenue and or price growth. And those caps can be tied directly to the cost growth benchmark, or they could be different. This direct regulation of hospital revenue and prices will have enormous impact. It does require a pretty significant regulatory mechanism. And a little bit to the question, Jane, that you posed earlier about, so what happens if they don't meet it? You have to have some back-end monitoring, and you have to have some corrective actions if they skirt the restraints. And this was an issue this past year in Vermont, where they had their largest medical center just fly right through the cap by literally tens of millions of dollars, which I think spoke to a weakness in their program design, but was remedied through, at least in part, but through state action subsequently. Delaware is a new state doing this. And I want to spotlight Delaware for the reasons shown on the next slide. So the new Delaware Diamond State Hospital Cost Review Board just started meeting. The legislature in Delaware created this board in part because the state was consistently exceeding its cost growth benchmark, and by a lot. Delaware's probably had the highest trend of all the cost growth benchmark states, and legislators pointed to that and said, we've got to do something because you all are not constraining your spending growth. And so they created this new review board, which regulates hospital budgets, or will, starting in 2026. For a couple of years, they are capping hospital price growth on an annual basis. And then if hospital price growth exceeds the benchmark, thereafter, they're going to have to submit an annual performance improvement plan to curb cost growth. And if they do not meet the plan or produce an acceptable plan, then the board can approve or modify the hospital's budgets. Again, this is just being stood up, so I can't tell you how it's going to work or if it's going to work. But this was an action taken by a legislature that was fed up in part because of continued failure for the state to hit its cost growth benchmark. So that is a pretty lengthy list of options for you to consider, and all strategies that other states in some fashion are either doing or actively pursuing. And I think they provide evidence to the fact that hospital cost growth and specifically price growth has been a high priority in every state. So let me stop there and invite your questions and observations. Margaret.
Really appreciate the presentation. and I think it gives us a lot to consider. I'm wondering on item 7, how that compares to our state's history with the Hospital Rate Setting Commission, which goes back decades. And, you know, how is it the same? How is it different? But as I look at these last 3, you know, I'm feeling that it's worthwhile for us to take on something big rather than nibble around the edges, which I think we've been doing for a long time. And that it may cost money to implement it, but I think the results are likely to be much better.
Yeah, I mean, I would say that some of these strategies are going to produce a more certain impact than some of the others, and a larger impact. To answer your question about rate setting commissions, so not just Washington, but lots of states used to have them. How does this differ? These states have not, well, I can only speak to Vermont because Delaware hasn't done it yet, but Vermont did not get into setting rates. They got into reviewing and approving budgets and revenue growth and prices in relation to revenue growth, but they didn't actually get into setting prices. They said, look, your commercial prices as part of your revenue projection can grow X% this coming year. But they didn't say an X-ray of the knee is going to be $102. Does that help?
Yes, but I think I would like to request that staff give us a comparison on how the rate setting commission in Washington worked and how some of these proposals would be the same or different.
Thank you, Margaret. This is Ross Valori with HCA. I guess, Margaret, I'm wondering if you could provide a little bit more details about this rate setting commission you're referring to.
We do have that background already, Ross, and there was a recent presentation, in fact, to the Universal Healthcare Commission, so we can bring up some of those materials and carry them forward. So I'll connect the dots.
Okay, thank you, Michelle. And Margaret, I guess I'm wondering what you're hoping to glean from the comparison.
Well, I would like to know what worked and what didn't work with the Hospital Rate Setting Commission. And how does it compare to how these new ideas would work? But in general, I'm in favor of analyzing hospital expenditures to look for the opportunities, and you know, some kind of review, and CAP is likely to do that. So I think we need to learn from that experience.
Okay, so taking a look at that rate setting experiment and whether it was successful at slowing cost growth, that's kind of what you're looking for, Margaret?
Yes, and also I think it kind of makes it more logical when you're looking at the same data from all the hospitals.
And so, Margaret, just to add to that, I think the methodology that Washington State used, if I remember correctly, was literally like almost like fee-for-service rate setting, where you're going service by service by service, as opposed to the approach that Maryland takes, which is sort of building a global budget for the hospital and building in to their global budgeting incentives and structures to promote, for example, more investment in primary care.
Yeah,
so
the global budgeting has a lot more appeal.
Right, so I think it would be helpful if we're doing a comparison to bring in Maryland, given the fact that it is a state that has been doing this now for what, Michael, 11 years? I think they started in 2014, and it is all payer, right? So that's different, but they have more success than anybody else, I think.
That's a good idea.
Yeah, they used to do rate setting service by service by service, but they moved to global budgets a while ago.
Yeah.
Carol, I see
Carol?
your hand is up.
Yeah, Michael, in any of these examples that you gave, are there hospitals that are excluded, or are they truly all hospitals?
Yes. Yeah. Yeah, because the problem of high hospital prices and fast growing hospital prices is not uniform to all hospitals. And that's a nuance that sometimes gets lost in these policy conversations. The problem of high prices and fast growing prices is most acute with large systems that have a lot of power, and sometimes with independent hospitals that might have a geographic monopoly and a lot of power. But there are, in many states, um, uh, independent community hospitals that are struggling and have low prices. And there are also, many, many critical access hospitals that are so small, and their impact on healthcare spending within the state is just de minimis compared to that of the larger hospitals and systems. So, yes, you can have exemptions for hospitals by class of hospital. You can also have exemptions based on financial status. And as I said earlier, when I cited the California example, you can also have variation in expectations. So California created a lower target, or really a growth cap, because they've got enforcement for the very highest hospitals than for all the others.
Thank you, Michael. I see that we're about 5 minutes over time on this topic, and we haven't begun the next part of the discussion on assignments for the advisory committees. Look to Ross to give me a time check, but we have 2 extensive discussions yet to come. We'll move through this discussion.
Yeah, thank you, Michelle. Michael, if you don't mind, if we could transition into the kind of discussion and identification of policy levers, I think it will fit nicely with some of the questions that you've been receiving here. That sound good, Michael?
Yeah, absolutely.
Okay, I did not want to cut you off. Is there anything you wanted to finish?
Nope.
Okay, excellent. Thank you so much, Michael, for that presentation. And so just following up that great presentation, in Harrison's presentation, what we're trying to do, cost board staff, is trying to think about how to move the board's work from the data research that we've been in for the first roughly 2 years to this policy focus. And so we brought in Michael to go over some of the options. We're calling them policy levers, to be able to actualize some of these mechanisms to slow cost growth. And so, but it has been a little bit of a difficult process envisioning which tools would work best and kind of how to present this to the board and figure out which policy lever the board would like to select to move forward with to kind of drive work for the remainder of probably 12 to 18 months, I would assume, to kind of really actualize and scope out the work around a policy lever. And so we want to take a few minutes today after that policy lever discussion to see what information would be helpful to cost board members as we hopefully work over the next 3 meetings towards selecting a policy lever. We had an excellent question from Margaret about the rate setting commission, and Jane mentioned that adding Maryland into that comparison would be helpful for folks to understand more about the policy levers. And just wondering if any other cost board members had other pieces of information that would be helpful for you to know as we intend to meet with the advisory committees next month and solicit their feedback on these and bring that back to the cost board at the June meeting. And really hoping at that June meeting that the cost board can identify a policy lever that they would like to work on over the course of the next 12 to 18 months. But wanting to make sure that we don't rush that decision and provide the information that you need. So would like to just open it up for a few minutes just to see if there's any additional piece of information that would be valuable for the cost board. Yeah, Jane, go ahead.
So I'm going back to the non-claims payment question. And while the legislature did act on reference-based pricing, right? Reference-based pricing is claims-based. And so I think looking at options that allow us to address both claims and non-claims expenditures would make more sense. I mean, my understanding is if people are still committed to value-based payment, right, still looking at wanting to encourage bundled payments, wanting to encourage subcapitation or whatever, that doing strategies that focus only on claims may be contrary to the trends that we're trying to get at with respect to value-based payments.
So Jane, you would be more of an advocate of kind of a double dipping sort of policy lever that's looking, like you said, at both.
A lever that can impact both.
Right. Okay. And do you have any suggestions, Jane, of any of the 7 policy levers that we reviewed in addition to the one that you mentioned that could kind of get at that?
Well, I mean, the ones that address, right, growth caps, because then you're looking at growth expenditure. You're looking at it across the board in terms of spending. And I know we've had many discussions about, Rhode Island. One of the distinctions between Rhode Island and Washington is that Rhode Island has the authority, their insurance commissioner has the authority to review and approve large group rates. You probably remember, Ross, from your time at OIC, that we do not review large group rates that are negotiated. So taking on number 5, while we have always been really impressed by what Rhode Island has done, means looking at whether the OIC should be given authority for prior approval of large group rates. So it's sort of a corollary of taking a look at item 5.
Thank you, Jane. That is incredibly helpful. Greg, I see you have your hand up. Please go ahead.
Yeah, I guess I was going to say something similar to what Jane just did, and it should, whatever we do should include everything, so claims and non. And similar to maybe the point Jane was just making, but it would be, as far as additional information, it would be helpful for me to understand, would any of the strategies that we just discussed, would we be able to leverage current regulation already in place or current legislation already in place in order to execute on those? I'm not familiar enough with all the Washington state regs to know, how could we do that? Because that can make a significant difference. And then I also would say, as a key consideration, I feel strongly anything we do should be based on something that's global and not service by service, whatever it is. I just the service by service challenges to me are almost too much to even figure out, but something that's global can be figured out, and highly effective in various formats.
I see Ingrid has her hand up as well. We're running out of time, so we need to pick up our pace here. Ingrid,
Thank
please go.
you. Yes, thanks for this discussion. Ross, I truly appreciate the shift to policy focus and moving beyond transparency. And one way that I would be interested in thinking about this is thinking about how can we build on the incremental measures that we've most recently gained. We heard earlier in this meeting about the healthcare registry bill, the APCD, the primary care, and importantly, the reference-based pricing as potential wins this session. How can we build on the strengths of where we've already gained some common ground and gotten things moving in a direction that could lead to meaningful impact? And reference-based pricing in particular, having started in the individual market and then in the PEPSED market, and just thinking about the next steps. So we're like building blocks towards impact.
Thank you, Ingrid. I love that point. And just one follow-up. So does that speak to just selecting one of these policy levers, or does that look more like looking to develop existing legislation further? So instead of kind of following the hospital policy levers, does that open up the door to some other type of policy action to curb costs?
I think you build on that bucket 4 that Ingrid would capitalize on some of those policies that are already identified, and some of those activities are already identified in bucket 4 and other conversations like reference pricing.
Sorry, Michelle, I couldn't hear you very well. I would just encourage that we build off of current wins rather than spending 12 to 18 months doing deep policy work, working up an elegant proposal that may not have legs.
This is Eileen. I'm just going to add, though, that we have to have some kind of enforcement. That there's nothing on the books, and I'm just as guilty as everybody else on this one. So that we need to pass something on enforcement.
And I'm hearing, it sounds like a comparison table where if we listed the 7 policy levers, and based upon some of the comments we have, that would distinguish whether there's existing laws that could be parlayed to help with enforcement or regulatory oversight. These comments we've been getting, if we were able to kind of present a table with those comparisons, that would be helpful to cost board members. Okay, excellent. That is something that we as staff can work on and plan to bring to our June meeting as well.
Yeah, I did see that Michelle Shadri had her hand up. Michelle, did you have a question or comment?
Yep. Thanks, Michelle. Just wanted to add something from the perspective of the team that supports the board's work. I would consider these strategies to be complementary in nature. So I'm not sure if maybe picking one out of the 7 is really the question. The question is maybe more about which 2 or 3 are we building on, like Ingrid mentioned, or do we have ready regulatory levers, like Ross mentioned, that we can then implement in the state and support, to Eileen's point with the enforcement mechanism. If none exists today, what factual basis can we present to the legislature to try and recommend an enforcement mechanism, as opposed to going in 12 different directions, like somebody mentioned. I would just encourage that we look at these as complementary, so we don't have to say, oh, which one should we pick? Maybe it's a combination of 2 or 3 that'll get us the progress that we're looking for. Thank you.
Thank you, Vishal. That's a really good point, especially as we were looking at the policy levers. Different states have different laws that would make them all look slightly different in Washington. And I think that speaks to your comment, Vishal, of there are pieces that maybe would fit better in Washington than others. So thank you. And I see Lois.
Yeah, I was just looking at the 7 options and thinking most of us seem to be thinking somewhere around 4, 5, and 6. So in, targeting that the way Vishal is suggesting, I think those are the 3 we're kind of looking at, maybe a little bit of 7. But I think for me, 1, 2, and 3 don't seem strong enough.
And Lois, is that partially because there's no easily identifiable enforcement mechanism for those?
Yes, 100%.
Okay. Thank you so much for that comment. And I noticed that we have gone past our agenda allotted times, and we had a discussion planned for the end of today's meeting where we would go over reflections from the advisory committee feedback. And at our last advisory committee meeting, we had excellent feedback session from advisory committee members about their thoughts about the types of questions and feedback that they're given and how to interact with the board that we wanted to share. But seeing that we only have 17 minutes and thinking that that is worthy of a more holistic conversation, I think we'll save that for the June meeting and just stay on this topic, because I know I have a few more questions that I'd like to ask.
I'd like to interrupt and suggest we wrap up this conversation, because we will bring this back to the June meeting and have Joe complete his overview of the ASI, because we do need to have a brief introduction on that so that he can complete that product for us in June, because the grant is ending and we just need to keep progress on wrapping up that conversation with Joe. So shift gears. We know that we're coming back to discuss all these policy levers in our June discussion, and it will relate to some of the legislation that we can summarize and how those other efforts, to Ingrid's point, we can build on related efforts. There are several related conversations in legislation and budget related items, so we'll bring those back in June. I would like us to move to the next conversation with Joe.
Great. Should I jump in then?
Yes, please go ahead, Joe.
Great. Thanks, everybody. It's a pleasure to be here representing the Analytics Support Initiative. We can jump to the next slide and I'll move quickly. So some of this slide you've seen before. Just as a reminder, it's been a 2-year project and we really have about 2 months left, about maybe 3 months left. So the lion's share of the project is over, but the primary focus and what we've done is focusing on Washington-specific analyses, looking at cost growth, and mostly been generating information. We had a report that we provided earlier. Today, my topic is really 2 things. The first is, and I'm going to actually do them in opposite order, so maybe I'll say the second is to do a short tour of the interactive visualization that provides what will eventually be a public way of accessing the data that we produced earlier. And so eager to show you that, kind of a sneak peek, and also, as time permits, take any feedback on that. And then the first thing on this list, which is the second thing I'll do, is very briefly, I'll remind you of kind of the analyses that we're doing with the last bit of time. I think the last time I presented, there was a specific request about starting to identify causes, health conditions, I should say, that we would look into. And so I'll talk briefly about that, but we'll move relatively quickly given the time. So the first thing I'll do is, like I said, the second thing on the list is a preview of the interactive visualization. So I will share screen now. I hope this works. Great. And I'm hoping you can see a map of the state, which I think you can.
Yes, we can.
Great. Thank you for the thumbs up. Okay, so this is the interactive visualization that we've been working on. It's not publicly available yet, but really what it does is report at a fairly granular level a wide variety, a wide set of estimates that we've made. And so you can see on the left side, there is essentially a control panel that allows a user to customize what they're looking at. And so I'll take the next 4 or 5 minutes and just highlight some of the features that exist here. So the screen we're on right now is just looking at total healthcare spending in the state of Washington by county, and blue is the dark blue is where we spend the most money. And so this is no surprise that that King County has the largest amount of spending with 19 billion. I think Pierce is second, and some of the other counties with the most spending show up in these kind of colors of orange and yellow. This is, of course, where the people live. So it's not a surprise that this is where the spending is occurring. So the first thing that I want to highlight is that we can switch over, and instead of just looking at spending, we can look at spending per capita. And of course, the map looks very different when we switch over and look at spending per capita. The blue is still the bigger numbers, but we can see that there's a lot of spending in per capita terms throughout the state. And you can see in per capita terms, our estimate for King County, still the biggest, is at $8,288 per person. One thing that's important to recognize is that some of the states are older. Oh, maybe I'll switch here. Some of the counties are older versus younger. And so the drop-in screen that I was just showing is age standardized estimates. And so what I want to do is switch over and show you this map in not age adjusted kind of denomination. And so right here, you can see that, again, King County is now not standing out, and that's because it's a relatively young population. And some of the older populations here in the Olympic Peninsula stand out as having more spending. And so this is, of course, a function of who's living in each of these places. And so I can switch back now to the age standardized estimates, and you can see a really remarkable change. So Jefferson County, which is the oldest population in the state, in age adjusted dollars is spending almost $6,000 per capita. But again, if I don't adjust for the fact that it's an older state, you can see that in true numbers, it's spending over $8,000 per person. So this allows us to really make concrete comparisons across the counties and see really where the spending is occurring. The next thing that I wanted to highlight is looking at payer-specific estimates. And so this is now looking at Medicaid spending. And again, it's still spending per capita. And we can see where the most spending is happening. But of course, if we're looking at Medicaid, it's not so interesting to look in per capita terms. What we're probably more interested in is per beneficiary terms, because there's different amounts of people on Medicaid in each one of the counties. And so now we're looking at specifically Medicaid spending, and we're looking at it in per beneficiary terms, and it's age and sex standardized, so you can see where the state is spending the most per beneficiary on Medicaid. If we're interested in a specific type of care, that's modifiable as well. And so just for example, I'll just highlight ambulatory care. And so we can see here that there's places where there's substantially more spending per beneficiary on ambulatory care. The cool thing about looking at a specific type of care is that we can start to look at utilization as well. And so now I'm going to switch on our metric here to the encounters per beneficiary, which now tells us a little bit about utilization. Where are, again, we're still on Medicaid. Where are people on Medicaid using ambulatory care the most? And again, blues are the biggest numbers, and this is in per beneficiary space. The very second to last thing that I want to show you is kind of our measure of spending per encounter. This is the closest we get to reporting on price and intensity. So this says, per outpatient visit, how much was spent. And so this is ambulatory care. We can switch back to all payers, and we can see a sense of like where are prices and intensity of care the highest. And so this is ambulatory care. We see a similar pattern if we switch over to inpatient care. Again, the blues are the highest. And so we can see some of the places where people are living that have the highest spending per encounter on inpatient care. The very last thing I'll show is that there's this cool feature over here that is location detail. And I've been showing you a map on Washington state counties, but we can look at other breakdowns of the state as well. And so I'll just highlight here is the Washington Accountable Communities of Health that we could look at. It's a different map. It highlights, again, we're still looking at inpatient spending. If we want to just go back to per capita estimates, we can see, again, across those ACHs, where the highest spending is in per capita terms, where the lower spending is. So the visualization is really powerful. It has other features that I didn't go into. You can look at spending by disease. You can look at changes over time. So it is a relatively powerful tool that shows a lot of the work that we did over the course of the last year and a half. So I will stop sharing, but happy to take any questions or comments while the slides get pulled back up.
Joe, super quick question. Is this based upon where the service was provided or where the consumer lives?
Yeah, it's where the consumer lives. Yep.
Okay, thanks.
And maybe that's great feedback that we can make that more clear on the top. Good. If we could go back. Yeah, so I'll stay on this slide. One of the things that I presented on last time we connected, last time I presented, was that we're going to be doing some analyses on utilization of services and preventable admissions or potentially avoidable admissions to hospitals. And so one of the requests that had come from the cost board was just a little bit more knowledge, more understanding of what health conditions we were going to be looking at. I think that is still to be determined precisely, but I wanted to highlight these two existing lists of analyses that people have done that are very similar to what we're trying to do. So on the left is a list of health conditions that CMS has considered potentially avoidable hospitalizations. And so we will likely look at some of these. On the right is what ARC has looked at with ambulatory care sensitive conditions. It's a similar list. There's some overlap. And again, these are the kind of the lists that we'll be pulling from. The other comment from last meeting was the question about including some behavioral health conditions, and that's very much on our agenda as well. And so we don't yet have a concrete exact list of the health conditions we'll be assessing, but this is the kind of list that we'll be pulling from.
I see one of our board members has his hand up, Ken.
Yeah, Joe, I just wanted to ask that mapping model is fascinating. Is that something that we can access directly?
So I can send you a password to get early access, and then we're going to make it go live. We'll put out a press release and try to get some attention so that other people know about it. And then it'll be publicly available. Yeah.
Fabulous. Thank you.
Great. Thanks so much.
Thank you, Joe. Appreciate the wrap up quickly on that ongoing project you've been completing for the grant project we have with Gates Foundations and Pearson. Thank you for wrapping that up. I think you'll be back in June, as I understand. I'm looking at yours for August. We'll be back in June with that conversation. And thank you, Ross, for pulling the final agenda that Eileen was going to review for us from the committee discussions. We'll push that out. We don't think you can do that in 5 minutes. Maybe you want to run through a quick 5-minute version, but we want a lot more time on that yet. So we will have a few more things that we bring back for a pretty meaty discussion in June. Is there anything else that we missed at this point, Ron?
Yeah, thank you, Michelle. Just wanted to encourage folks, again, on the hospital policy lever discussion, if there are additional areas or any feedback you have as we're kind of thinking ahead to the June meeting and what information to bring to help inform a decision towards a policy lever, we'd love to hear that. So please send us any additional feedback you have on that. And again, just thank you to the team, Harrison and Jen, our internal cost board staff, for all the work kind of developing that. And thank you, Michael, for that presentation as well. I'll give it back to you, Michelle, to close this out.
Thank you, everyone, for attending today, with our audience and our board members. We appreciate the time and effort that everyone contributes to these discussions. The recording of this meeting will be posted shortly on our website, and our next meeting is June 3rd from 2 to 4 p.m. Continue the discussion of these policy levers.
We think about a longer meeting.
If people are willing, we can certainly add an hour. June 3rd time, assuming we have a room available, but I'm sure we can get back to you. That'd be great. All right. To do it for planning purposes for Bergen, we'll try to add an hour and we'll see what our options are here for that. that, we'll look forward to seeing everybody in June. A lot of good meeting things to talk about. Thank you all. Meeting is adjourned.
Thank you.
Where were we at?